Here we're looking at an orthokeratology case. The patient had some complaints of near blur, presumably due to some uncorrected astigmatism. Distance division was satisfactory, and what I have up right now is the same lens in two windows. I'll be making changes on the right side, and we'll leave the left side open for comparison and reference. Before getting started, however, I just wanted to point out a few things that I think make this a particularly challenging case. And the first is, if you look at the topography in the lower right corner, it shows slightly less than half a diopter of what the rule astigmatism. However, the patient's spectacle refraction shows 1¼ diopters of cylinder at axis 60. So this indicates we're dealing with lenticular astigmatism. And with corneal molding, we can mold out corneal cylinder to a degree, but sphericalization of the cornea does not improve lenticular astigmatism, and in fact, it sometimes makes it worse. We're finding, or you're finding, with your post-wear refraction that all of the cylinder remained in the right eye. It was decreased some in the left, but not to the degree that the patient was getting satisfactory vision. Second, if we look at the left eye, the cylinder component of the refraction is slightly greater than the spherical component of the refraction. And because cylinder is difficult to treat, especially when it's lenticular, it's challenging to get a patient to a satisfactory vision when that cylinder component makes up a majority of his or her prescription. Now, having said all that, the question still remains, is there something that we can do to possibly help this patient? And my response to that would be maybe. The prognosis for success is quite guarded, I would say, and the two options I would look at are to first overcorrect the patient slightly so that we're a little bit closer to a plano equivalent dioptric sphere over refraction, or to try to specifically address the cylinder itself. So the first option is a little bit easier to do lens-wise, and if you do a loose lens over refraction while the patient's looking at a reading card, it's probably not too hard to tell whether or not it's going to work. So if the patient does appreciate some improvement in near vision with -1/4 or 50 or whatever it may be, then I would take that approach first. It's a little bit easier to do. I know in the history you'd indicate this patient has a tendency toward esophoria at near, and you wanted to make sure that the patient was not overcorrected to further, which would result in further breakdown of binocular function at near. With corneal molding, and I presume it's due to the asphericity of the treatment zone, I find that there is slightly less tendency for accommodative convergence compared to the same correction in a pair of glasses. On top of that, we can use WAVE to design an aspheric treatment zone to help the patient possibly maintain good binocularity still, even though he or she will be slightly overcorrected. So if we want to take that approach, it's not too difficult. What we want to do is find out what overrefraction helps the most at near, and if we say, for example, -1/4, what we want to do is just increase the power of this lens to, for example, plus 1.47. So in 100% mode, I'm just going to click up here on the control point until we're close to 147. That's a little over. I'll drop down a little bit. And I often find that when changing the power or demand of the lens, it's good to go through the meridians to make sure we're pretty close to our target. And I think we might be able to get a little bit closer in some of them. So I'm going to go to 25%. And if I drop that down, well, we'll keep that at 151. And a lot of this will be kind of trial and error. So now I'm pretty close to a power of 1.47 in all meridians. The patient is slightly overcorrected, And in order to help maintain good binocularity, I'll go down to the bottom and introduce some positive asphericity. So if we go to the back surface power and compare it to where we started with an 8.16 radius, and we're actually a little bit steeper now. So we're not correcting as much minus centrally in this lens. If you go further out, the lens does flatten, and that's where we're getting the myopia correction. But this reduction in minus correction in the center may help the patient maintain or avoid that accommodative convergence that was previously a problem and corrected through spectacles. So this is possibly one thing we could try if you find that a little bit of minus in an overcorrection does help with near. If you find that it does not help, then the other option is to tackle the cylinder directly, and I'm going to pause the video while I reset the lenses, and then we'll look at that. Okay, now we're back to the original lens again on the right side. The overcorrection strategy that we just discussed, honestly, I'm not sure if it's going to help that much because the patient is pretty close already to a plano EDS, but it's a straightforward change to the lens, and it does give us predictable results.